Hey Adam, can you tell me a little bit about the experience you're having right now?
Constant chest pain, fever, reduced appetite, and fatigue.
Any bloody coughs?
Yes.
You poor thing. We'll conduct some tests. In the meantime, take some rest.
Okay.
I believe white plague has consumed the most.
Tuberculosis, or TB for short, is an airborne infectious disease caused primarily by the mycobacterium Tuberculosis bacillus. TB usually begins manifestations and remains localized in the lungs, known as pulmonary TB, whereby the pathological hallmarks include tubercle-shaped nodules, known as granulomas, and pulmonary cavities. However, for approximately 2 out of 5 Australian patients, TB may spread via the lymph nodes or the bloodstream and disseminate to other extrapulmonary organs and tissues. This is known as extrapulmonary TB and causes multiple secondary complications. In 1882, Koch discovered the main causative agent for TB was Mycobacterium tuberculosis bacilli, and in some rarer cases, closely related Mycobacterium subspecies. They have a rod shape and a waxy mycosilic acid cell envelope which protects it from drying out and weak antimicrobials. They are aerobes and have a long generation time, producing delayed symptoms. Aerosol droplets of Mycobacterium bacilli are initially inhaled and travel along the airways. They pass through the ciliated bronchial epithelium and mucus traps. However, only a small fraction of bacilli, usually 5 micrometers in length, enter the alveoli. Upon its entry, its mycocolic acid cell wall helps protect it from antimicrobials in the alveolar lining fluid. Next, alveolar macrophages rush into the infection site. They engulf the bacillus into a phagosome via interaction of its toll-like receptors with the mycobacterium surface proteins. Lysosomes usually fuse with phagocytes and degrade its contents. However, the mycobacterium overcomes this defense by utilizing intracellular virulent factors. It releases PTPA protein, which inhibits phagosome acidification, and chronin 1, which prevents fusion between phagosomes and lysosomes. As a result, the bacillus proliferates extensively by binary fission, and it begins to degrade nearby extracellular matrix and blood vessels by releasing collagenases and proteases. This stage is known as primary TB and causes coughing of blood and flu-like symptoms. After 3 weeks of primary exposure, macrophage's cellular function becomes altered, causing it to release cytokines to trigger cell-mediated immunity. T lymphocytes are attracted and then stimulated by macrophage antigen presentation to destroy and wall off the replicating bacillus by forming a granuloma. This occurs successfully in latent TB, an asymptomatic form of infection which occurs in 90% of all TB cases. The intact granuloma essentially compartmentalizes TB and limits its replication and spread, causing the bacilli to undergo casus necrosis and go dormant. Afterwards, calcification and fibrosis of internal cells may also occur, which is called a rank complex. The granuloma and rank complex can be observed in X-rays. The remaining 10% of TB patients suffer a symptomatic form of infection called active TB, whereby the immune system fails to contain the infection. Predisposing factors including immunocompromised conditions such as HIV, malnutrition, chemotherapy, or low natural immunity causes the granuloma to rupture as TB reactivates. The memory T cells intensify immune responses, which ultimately fail, causing liquefactive necrosis and pulmonary cavitation as collateral damage. TB continues to spread into the upper lobes in search for more oxygen and extrapulmonary tissues, causing more damage and complications along its way. The fever, coughing of blood, and chest pain in Bill is a direct result of his immune response, as well as lung and vessel damage caused by the bacteria. His weight loss and reduced appetite is attributed to the body's hormonal changes caused by hypoxia, causing a phenomenon known as wasting. Lastly, his ashen skin could represent inflammation-induced anemia, hence the reason TB was nicknamed the White Plague in the 18th century. Tuberculosis incidence and mortality is low in Australia, with approximately 14,000 new cases in 2017, with 0.2 deaths per 100,000 people. Yet there has been a moderate increase of incidence in young children in the last decade. HIV patients with latent TB have a 10 times greater risk of developing active TB than other patients. Moreover, the indigenous population have a 6-fold greater rate of TB infection, especially individuals over the age of 45. However, 85% of cases come from Australians born overseas, with a 20 times greater likelihood of infection. This is likely due to reactivation of latent TB, which was contracted overseas.